You might need to be a little bit more on top of it. Okay, so I'm gonna do the ulnar nerve upper limb tension test. This is used both as a neurodynamic assessment for the ulnar nerve and also as a treatment if the patient does have symptoms with this process. So first I'm going to apply a depression to the shoulder. Ask the patient, do you have any symptoms there?
No.
Okay, so then I'm going to take the arm into abduction. Do you have any symptoms there?
No.
And then we're gonna push it into external rotation. Do you have symptoms there?
A little bit.
Okay. So if he has symptoms here, then I would typically make this part of the examination my treatment as well. But for demonstration purposes, I'm gonna go ahead and do the rest of it. All right, so then we're gonna go ahead and move the forearm into pronation. Any symptoms there?
Not really.
And then we're going to get finger and wrist extension, making sure that we get all fingers. Symptoms there?
Not really.
And then we're going to bring it into flexion. Any symptoms there?
A little bit.
And then if the patient could tolerate it and there was no symptoms or pain here, then I would also have them do a lateral side bend away from the right shoulder. So we did lateral side bend to the left shoulder. Okay, so if I have a patient who is demonstrating radicular symptoms, then I can do a cervical manual traction distraction. And so what I'm gonna do first is I'm gonna find the base of the occiput and just do a very gentle one to begin with my fingers there, pulling back. And then to get some more force during this, I'm gonna go underneath the head, again with my grip at the base of the occiput. This top hand here is basically just to stabilize. I'm gonna pull with this bottom hand and try to sit back into it because it is gonna take quite a bit of force to relieve symptoms here. And then again, we're gonna look for symptom relief with this process. Okay, so if a patient is coming in with any symptoms consistent with a cervical radiculopathy, such as sensation, numbness, tingling in a dermatomal myotomal pattern, then we can do an assessment for cervical radiculopathy. I'm going to demonstrate the hyperflexion test. All you're going to do is ask the patient to go ahead and flex your neck, so bring your chin to your chest. The patient is going to go ahead and do that either to the point of pain or symptom reproduction, or if they don't have any symptoms or pain with that, they're going to go towards the end range of motion. A positive test is going to be the reproduction of symptoms, the numbness, or pain. Okay, I'm going to demonstrate the modified sharp purser test looking for cervical instability. We're making sure that the cervical spine is able to hold itself under loads to protect the neurovascular structures within it. I'm going to be looking for a few things here, such as excess translation or any symptom reproduction or pain. I'm going to first ask the patient to just gently flex the neck, not quite all the way. There we go. So just a small flexion with the neck. Again, I'm going to palpate at the base of the occiput and go down until I feel that first spinous process. So what that's going to be is C2. I'm going to stabilize C2 with my index finger here. And I'm going to apply a force posterior to anterior, or anterior to posterior with my hand on the forehead, looking for any translation about that axis there. And then a positive test for this is going to be if the patient had any pain or symptoms, either with the neck flexion. So did you feel anything when you bent your neck down?
No.
Okay. And then I'm also looking for excessive translation in the anterior to posterior direction. And then another something else that would be indicative of a positive test would be if the patient did have symptoms, but the symptoms were actually relieved as I applied that anterior to posterior force. Okay, I'm going to demonstrate one of the special tests for thoracic outlet syndrome. I'm going to do the hyperabduction test. What I'm going to do first is have the patient in seated posture, sitting up straight, and I'm going to go ahead and assess the radial pulse. And after I feel that for a few seconds, and I can feel the integrity of it, I'm going to ask the patient to assume a 90-90 position. And then have your arms both sides. You're going to externally rotate on both sides, and I need you to hold this position for 1 minute, a little bit higher, and then externally rotate him. Yep. So the patient would hold this for 1 minute. After he has been there for 1 minute, I'm going to reassess the radial pulse, and I'm looking to see any changes in that. You can go ahead and put your arms down. If he reports any changes in sensation or any reproduction of symptoms, or if there is a change in the radial pulse, then that would be a positive test. Okay, so I'm going to demonstrate how to set up for a high velocity, low amplitude thrust manipulation. First, what you want to do is check the patient for VBI. What you're going to do is have the patient off the ends of the table. Go ahead and let your neck extend or to lean back. I'll hold your head for you. And I want you to keep your eyes open. So I'm going to first hold him in this position for about 10 to 15 seconds. What I'm watching for is any nystagmus of his eyes. I'm also going to ask him, are you having any symptoms such as double vision?
No.
Okay. So then we're going to rotate the head a bit to the right. Again, you would hold this position for about 10 or 15 seconds, looking for the same things. Are you having any symptoms there?
No.
Okay. And then we're going to go the same to the left. Let me have your head. And then holding that for 10 to 15 seconds. Do you have any symptoms there?
No.
Okay. So if the patient isn't having symptoms there and we've done the rest of our exam and we haven't noticed any instability in our exam, then it is safe to perform the HVLAT. So I'll have you scoot back onto the table and I'll give you the pillow back. Okay, so what I'm going to first do is I'm going to find the base of the occiput, and then I'm going to palpate the spinous processes. Typically the first spinous process that you're going to be able to palpate is C2. C1 is a bit more difficult to find. So then I'm going to go down to C3, C4, and then I'm going to use the lateral aspect of my first finger with the head rotated just a bit, making sure that my feet are pointed in this direction and my body is as well. I'm going to provide a posterior to anterior force out that facet joint, and then I'm going to lock it out in that position, and then a lateral shift, lock it out there, and as soon as that facet joint is completely locked out, you would do a quick but smaller range of motion thrust to the contralateral side. So I'm going to do it away from myself, and then that is what will get the actual pop in the neck at the facet joint.